Today we are very excited to present the topic of reducing healthcare professional stigma toward persons with opiate use disorders. My name is Dr. Jessica Pollard. I have the pleasure of directing Maine's Office of Behavioral Health and introducing today's speakers, as well as moderating the Q&A. So let me just give you a little bit of housekeeping before we launch into the presentation. And let's see here. So there are no disclosures for our presenters today, and while we certainly support their presentation, we also note that their views do not necessarily represent those of the Governor's Office or DHHS. If you are joining us today and are seeking continuing education credits, please complete the evaluation form at the end. We'll have about 40 minutes for the presentation itself, as well as 10 minutes for moderated Q&A. So you can put your questions typed into the box. Unfortunately, the formatting doesn't allow you to unmute, but I will read your questions to the presenters. And anything we can't get to by the end of the hour will be written up and shared with you after the fact. I want to call your attention to a few other events as well. We have we'd like to share information about the 3rd Annual Maine Harm Reduction Conference that's taking place on October 30th at the University of New England, and I will share that link with you all. And then November's Summit Seminar will be on Friday, November 6th from 11:30 to 12:30. If you are on this email invite list, you'll get the invite for that as well. And we don't have the title spelled out yet, but we'll announce it soon, and the topic will be on medication-assisted treatment. I wanted to also share with you that on September 24th, state leaders, as well as individuals representing affected family members and people in recovery, met to re-examine our state's opiate response strategic action plan in light of the progress that we've made over the past year, and examination of what has worked and hasn't worked, and also new challenges that we're facing in the context of COVID-19 and other changing circumstances. We've revised the strategies and identified new high priority activities. And stigma remains an important cross-cutting theme across all focus areas. We will, in the coming weeks, share draft versions with stakeholders of the strategic action plan in order to get comment and feedback before that is finalized, but we look forward to sharing that with you. And the presenters that we have today are Dr. Denise Bouchard, who is coming to us from Seaport Community Health Center in Belfast, which is part of the Penobscot Community Health Center. Dr. Bouchard is a family nurse practitioner since 2000. She recently obtained her Doctor of Nursing Practice degree with a focus on stigma reduction. She was lead investigator of a quality improvement project conducted in rural Maine aimed at reducing healthcare professional stigma toward persons with opiate use disorder. A timely topic, she continues to hold workshops to reduce stigma of addiction through various venues. And Silas Walsh, Silas Kushner Walsh, also comes to us from Seaport Community Health Center, and he is a conditionally licensed social worker with a certification in drug and alcohol counseling. In graduate school, Silas earned an interprofessional graduate certificate in gerontology and was a member of the Phi Kappa Phi Honor Society. More recently, Silas is practicing at Penobscot Community Health Center within Seaport Community Health Center's recovery program as a general mental health practitioner. Silas is passionate about supporting the self-determination of people in recovery while working to reduce the stigma associated with substance use disorders. And the reason that stigma is such an important part of our state's strategic action plan is, as you'll hear from the presenters, because it can be both internal, the person's own attitudes and experiences that are negative about their circumstances, and external. And I think when we talk about external stigma or the attitudes, the negative attitudes that others hold about an individual suffering from opiate use disorder or other stigmatized conditions, that we call that behavior what it is, which is discrimination. when people struggling with opiate use disorders face external stigma, it can lead to that internalized stigma, which in turn can lead to avoiding treatment and other resources due to the shame and negative feelings associated with internalized stigma. And of course, the external stigma and the behavior of discrimination is also a barrier to treatment and other resources for many individuals. So it's a really important topic, and we are thankful to Dr. Bouchard and Silas for presenting on it in more detail to us today, and I will turn it over to them.
So hi, I'm Denise, and thank you, Dr. Pollard, for that, and great synopsis of how stigma manifests in our world today. And so this is a presentation on a quality improvement project that was done, of which Silas is part of the team. So we all are aware of the opioid crisis going on, and that has been going on for years. And you can see the synthetic opioids here and how that really increased right around 2015. And Maine is among the top 10 states with the highest opioid related deaths. And this is from NIDA 2018, 418 drug-induced deaths in 2017, 85% of which at least one opioid is included. Mid-Coast region of Maine includes Rockport and Belfast. These are where the two interventions were done. Average 16.4 drug-related overdose deaths per 10,000 residents, reflecting the steady increases in emergency medical response overdose. Quick discussion about what addiction is. This is from ASAM, the American Society of Addiction Medicine, who describes addiction as a primary disease of brain reward motivation and related circuitry. And that brain circuitry gets altered, physically altered, thereby perpetuating addiction. Dysfunction in these circuits leads to what we see, biological changes, psychological, social, and spiritual manifestations. And this is reflected in an individual pathologically pursuing relief by using substances and other behaviors. This is where we see criminal behaviors and folks doing things that they would never think of doing otherwise. This is the ABCDE of addiction, characterized by inability to abstain, impaired control, craving, diminished recognition of any consequences, and of course, a dysfunctional emotion. So this slide is to give an idea of what happens. I'm not going to get deep into what happens with the brain when it is flooded with drugs of abuse, but just to give you an idea of dopamine levels and what happens to them. So normal dopamine levels on a good day around 50 nanograms per deciliter. And so on a really good day, we might have 100. So when we eat food, that goes up to around 150, sex 200. So this is wired into our brain so that we will continue to do these behaviors so that our species, of course, will continue. So when drugs of abuse are used, the dopamine flood is a lot higher, cocaine around 350, and you see heroin and other opioids, 500 to 950 depicted by this blue graph right here, and methamphetamine 1250. So when that happens, the brain is just flooded with dopamine. So this gives an idea that the brain tries to balance itself. And so this is the homeostasis point here. So it tries to go back to normal, but because of the actual physical changes in the brain, never will actually go back to normal. And so normal changes. So it's called allostasis. So it's an allostatic state where normal then changes. So it's downregulates, if you will. So, and we hear this from patients over and over again. I had to use more to get a high, and then I was just using so that I could feel normal. And that is because of this. There's a neurochemical rebound where reward function doesn't return to baseline, but drops below original levels.
Hey, Denise, we're getting a few comments in the chat about volume. I'm not sure if you could speak up a little bit.
And I'll turn it up as well. Is that a little bit better? We can't tell. I can see if I can bring it a little closer as well, and I will speak up.
We're getting some yeses from the panelists in chat, so.
Awesome. Thank you for that feedback.
Of course.
So lack of dopamine, if you think of addiction, somebody whose addiction is now going full force, there's a lack of dopamine. So they might have 10, 20 nanograms of dopamine when they get up in the morning. So what's the first thing they're going to do is look for a drug to increase that dopamine level so they can get out of bed, get out of withdrawal. So there's craving, they go into survival mode, and primal action. So this depicts, again, the lack of dopamine. So what we want to do in treatment is to augment the dopamine. And two ways of doing it, 2 FDA-approved medications for opioid use disorder augment that dopamine, being buprenorphine and methadone. This then stabilizes the craving, and so that folks with opioid use disorder now can get into recovery, and whatever that means for them. Going to individual meetings, group meetings, behavioral treatment for their comorbid conditions as well, going to work, reestablishing relationships with their family members or with their community. Addiction is not a desired condition, and treatment works. So medication-assisted treatment is what we've called it for years. There's now a new term today, medications for opioid use disorder. This has been shown that evidence-based treatments increases social functioning, retention in treatment, and decreases illicit opioid use, of course, criminal activity, infectious disease transmission, and opioid-related overdose deaths. Methadone is 75% effective, buprenorphine 65% effective, naltrexone is an opioid blocker, and that is 25 to 60% effective. But less than 10% of folks with opioid use disorder have access to these medications. And we're going to talk mostly about buprenorphine/naloxone. I'll just refer to it as buprenorphine from here on out because it can be prescribed in outpatient settings where methadone is prescribed for opioid use disorder in clinics. Medication saves lives. People die when medication stops. So this is a slide from Dr. Alexander Wally. He presented it at the 2017 NESAM conference, the Northern New England Society of Addiction Medicine conference. It shows that this is folks in and out of treatment on buprenorphine as well as methadone. So in treatment, you can see that the mortality goes up, at least doubles, off of buprenorphine. On methadone, in treatment, out of treatment, mortality goes up 3 times. This is pretty significant. So, crucial to closing the wide gap between treatment need and treatment availability, given the strong evidence for such treatments. So, why is this? So this is the question that came up that we were looking at. What was going on? Why aren't people coming into treatment? Why aren't people getting these treatments? Yes, there is a lot more folks that can prescribe buprenorphine now. You still have to get a waiver for it. And there is some legislation that is in the House right now to actually lift that waiver requirement, which would, again, increase access. So this was where the quality improvements project started. So this just gives you an idea of the timeline. So it was over about 2.5 years. So we began in February of 2018, and we did 2 workshops. We actually did 4 workshops because 2 of them we didn't use for the study. They were for our work sites that we did. But the 2 for the study were done at local hospitals in conjunction with the team here and in conjunction with the teams there. So just to give you an idea, so the first intervention workshop here was done in October of 2018, and the second one here was done in October of 2019. Quality improvement team consisted of myself, a project mentor, Dr. Tripp Gardner, and Seaport employees. We are a federally qualified healthcare center here in rural Maine. Consisted of physicians, therapists, medical assistants, a clinical pharmacist. The sites of the interventions were 2 local hospitals, and we partnered with them as well. So one of the first things we did was come up with we brainstormed and came up with this fishbone diagram and asking the question, why is there not adequate recognition of or treatment of addiction in primary care? That was the initial question, and that has changed throughout the project. And we looked at what's going on with patients, providers, primary care offices, the organizations, electronic medical record challenges, community and societal barriers, and look at what continued to pop up. Stigma. I just want to read a little bit about stigma. Goffman did a seminal book entitled Stigma, Notes on the Management of Spoiled Identity back in 1963. And this has prompted a lot of research on the topic. And he wrote that the term originates from the Greek referring to bodily signs showing something negative about the moral status of a person. He added that the term could be used to signify an attribute that is deeply discrediting, the bearer of which experiences discrimination, resulting in reduced life chances. Lincoln Fallon defined stigma as a simultaneous presence of labeling, stereotyping, separation, differentness, status loss where power is exercised, and discrimination which manifest as behaviors that exercise power over another. And Thorncroft describes discrimination as the behavioral consequences of stigma, further stating that stigma violates fundamental human rights, such as the right to health care. It also further contributes to low quality care and limited access to treatment, which is why we're here today and why we did this project. The aims of the project were to reduce healthcare professional stigma toward those with opioid use disorder. I mean, there were so many choices. Should we go out in the community? Should we work with patients? We decided there's a lot of stigma in the healthcare system because we weren't taught how to deal with addiction when we went to school back when. That is changing today, but it's still not mandatory in the schools. I already talked about the context, and we wanted to address the learning needs and also to increase willingness to provide buprenorphine as one way of increasing access. Why healthcare professionals? Well, we see people at the height of their distress. You know, we're in the emergency rooms, primary care, and there's a lot of pessimism about recovery and frustration, like what I do doesn't matter. I can treat them today, and then they'll be back tomorrow with another overdose, for example, in the emergency room. They see a lot of that, and so it's understandable that there's some frustration, lack of skills and confidence. Again, this goes back to we don't have the training yet in the schools, and so we need to catch up, essentially. And someday this addiction should and will be on parity with other chronic illnesses. It is another chronic brain illness. Lack of awareness of our own prejudices as well. And there is something called diagnostic overshadowing, where medical professionals may associate physical symptoms to psychological underlying conditions. And there's been a lot of studies that have shown there's attitudes of providers that are unwilling to treat, lack of empathy, motivation, a lot of reasons for this. What's most important is that we are pivotal in connecting patients to treatment. So this is just the PDSA process was used for the quality improvement project. This is just a couple to show what we did. And this went on throughout the 2.5 years. So we come up with a plan, reduce stigma among providers and healthcare professionals. It was initially, we were thinking providers, and it was extended to healthcare professionals because patients access the healthcare system, and it isn't only one person that they're seeing, it's everyone from wherever they touch the healthcare system. And so then we met with the hospitals, need result departments, healthcare professionals. We did literature search. We did surveys to target our population to see exactly what their concerns were. Then we chose an anti-stigma program to target the participants, and we started coming up with the workshop, and presenters got their pieces ready, and this went on, like I said, throughout the project. So the intervention that we used, and we're going to give you a snippet of this intervention today, it was a 2-hour workshop based on the Mental Health Commission of Canada's Opening Minds, Understanding Stigma. It targets healthcare provider stigma toward people with mental illness. And we did get permission to target it toward people with specifically opioid use disorder from the research associates at the Mental Health Commission of Canada. This is an important slide. This is the framework that we took, and then we filled in the blanks. So these are the 6 key ingredients that we used. The first one is facilitator who models a person-centered approach. Person-centered is absolutely crucial. So we would never, we wouldn't talk about folks as addicts, for example. It's person with addiction or person with opioid use disorder. They're a person first. The next is the social contact in form of a personal testimony. It's really important to hear from folks with the disorder themselves that are in recovery so that people can see that recovery is possible. Multiple forms of social contact because different people learn in different ways. So we had live speakers as well as video presentations. The fourth one, it was focused on behavior change by teaching skills that help healthcare professionals know what to do and what to say. So the way we did this is we came up with skits. And when we did these workshops, the skits were participatory. The folks in the audience were part of it. And they might play the part of a patient, or they might play the part of a provider. And we'd have them get together, go in the middle of the room, and we'd throw out a scenario. For example, somebody going up to the front desk and saying, I need my medication now, and really amping up and having a lot of anxiety. And so we would have the person respond incorrectly, if you will, and then we'd stop and we'd have folks from the audience give their ideas of how that might be done differently. How might it be presented better? How could we respond to this? So people actually could practice doing something different. Engage in myth busting. There's a lot of myths out there still today around these medications. One specifically is you're just replacing one drug for another. So that is really important to talk about that, because addiction is characterized, if you look in the DSM-5, opioid use disorder is characterized by 11 criteria, 9 of which are behaviors. So when you give a medication for opioid use disorder, those behaviors stop. Now somebody has opioid use disorder and it's in remission. So the addiction is no longer active. So that's why it's a medication. It's not replacing one drug for another. Emphasize and demonstrate recovery as part of key messaging, and that's throughout the whole workshop. These were 2-hour workshops that we did. Of course, we only have like 40 minutes today to present this, so we're giving you a snippet of what it's all about. So this is a short agenda of what we did for the workshops. We really mixed it up, and people seemed really interested and engaged as well, because we know that participation in this and really practicing it and looking at one's own biases, not knowing, maybe discovering one's own biases, not knowing that you have them, is really important to talk about this and to discuss it. So we did music videos, several PowerPoints, and different folks would do these as well. Like the first one, the brain science PowerPoint, was done by Dr. Tripp Gardner. It was great. We each did pick our own topic and present it and get the participants involved as much as possible. We did several first voice testimonies. Those were incredibly powerful, and there was time for folks to ask questions as well. We also did the skits, like I said, and myth busting presentation, words matter presentation, and Silas is going to do that very soon. And we also did video testimonies of recovering persons, group discussions. And so I'm going to turn it over right now to Silas, who's going to talk for about 10 minutes, and then I will then talk about what our results were when we looked at this statistically. Off to you, Silas.
Thank you so much, Denise. I'll still need you to change the slides for me, so I'll give you some sort of signal when the time is right. So my name is Silas Walsh. I've had the distinct pleasure of working with Denise for the last 2 years. Together, we co-facilitate several weekly recovery groups, as well as work on these workshops. You know, working with people with substance use disorder is some of the most challenging and rewarding work that I get to do. One of the facets of working with SUD treatment that is the most frustrating for me is that there's a really meager percentage of people who are, you know, engaged in active treatment. And living in a rural state, there are many barriers to treatment, some of them very tangible and physical. But there are other barriers that can be more insidious. And, you know, what we've talked about today a bit, and we'll continue to talk about, are some of the societal and institutional stigmas that, when internalized, can drive people away from treatment, and in some cases towards much bleaker outcomes. Part of my weekly routine as an SUD clinician is to read my local paper. And when I do that, I'm looking at obituaries and I'm looking at arrests. And that can feel really overwhelming at times. Societal and institutional changes often happen slowly, but what I see is an opportunity here. So much of SUD treatment exists beyond our realm of influence. But one thing that we can control is our language. And today I'm going to talk briefly about why words matter. And I'll look forward to that next slide. Now, when I say control our language, I say that with a bit of a caveat. I'm a graduate of the University of Maine School of Social Work, and person-first language is something that we practice every day. You know, and it got to the point where even the use of stigmatizing language around me started to sound like nails on a chalkboard. And when I graduated and moved into the workforce, I was ready to take on the world. And then I was forced to face this dark reality. I make the mistake of using stigmatizing language frequently, always accidentally, but I never seem to be able to catch myself in time. I'll usually blurt out some awkward mid-sentence correction and end up feeling embarrassed and unqualified to do my job. Person-first language is one of the cornerstones of my education and one of the hallmarks of my field, and I still get it wrong. I don't see this as a failure of training or education, but more of a culture that needs changing. I really believe that the way our society views people with substance use disorders is a powerful contributor to the scope of the problem. On the screen now, we have some examples of stigmatizing language. Addict, former addict, alcoholic, you know, using an opioid replacement, swapping one drug dealer for another, having a drug problem or a drug habit, a drunk, drug abuser, junkie. You know, how many times have I heard a dirty urine screen? You know, these are all examples of stigmatizing language. And I firmly believe that person-first language has a huge potential benefit in enhancing the relationship between a client and a provider. I never make a point of correcting someone who self-identifies as any of those things on the screen, as an addict or junkie or drug abuser. But what I do is I attempt consistent use of first-person language throughout our clinical relationship, with the hope that that will create opportunities to talk about changing language, and by extension, help people to reframe how they view themselves within the context of the disease. Stigmatizing language contains the implication that the person is the problem, and that must feel so invalidating and depressing and lonesome. What clients share and have shared with me is that they can internalize some of that stigmatizing language and then end up viewing the behaviors, you know, we've talked about behaviors that are associated with substance use disorder, like relapse, for example, as proof that they're, I mean, I've heard the terms bad, not good enough, failures, or even unworthy of love. And I think this is very dangerous. The type of external validation of an internally held belief can be really powerful. It can contribute to a stuck cycle that people fall into, in which the behaviors that they're using to cope with the anxiety and depression instead lead to more anxiety and depression. This is also very evident when clients talk about their relationship with their primary support system, their families, and how important that is to their recovery. One of the frequent conversations that we have in our groups and in my individual meetings with clients is how difficult it can be to rebuild trust with family members, especially after periods of active use and some of the behaviors that may be associated with that active use, lying or stealing, etc. Clients report a lot of guilt and shame related to these previous actions that can feel really overwhelming. And so when they hear stigmatizing language from family members or friends, or even on social media, especially in early recovery, it can feel really devastating. This is what people say. How about the next slide, Denise? Fear-based language. Oh, this is one that we hear a lot. Fentanyl is scary. You know, heroin is so dangerous these days with all the stuff people are putting in it. People are dying out there. You know, I'm guilty of this. I sometimes slip up and use fear-based language when I'm talking to someone. And generally speaking, what I'm conveying is my own fear and my own investment in caring about that outcome. But what I hear time and time again from people who hear me or other providers using fear-based language is that somehow they're stupid for continuing to take these risks, or that they're guilty of a moral failing or weakness because they can't simply stop doing these bad things. And, you know, it reminds me of one of the diagnostic criteria in the DSM-5 for opioid use disorder. And that's, you know, continued use despite the knowledge the substance may cause physical or psychological problems. I mean, people know that what they're doing is dangerous and risky, but fear-based language comes across as a judgment. Clients have told me that one of the sure ways to create a gap or divide in our communication is to fall back into the use of fear-based language. And people report that it doesn't feel collaborative or supportive. And people may even push back, suggesting that the provider doesn't know what they're talking about or could never possibly empathize. And that can create a real gap. Next slide. Finally, you know, moral judgments in our language can have really unintended consequences. Moral judgments inevitably marginalize people who are vulnerable. And some clients mentioned to me how they feel judged even coming into our office for our recovery group, or picking up their prescriptions at the pharmacy. Many have shared that they avoid addressing medical concerns for fear that their behavior will be labeled as drug seeking. Some of the most heartbreaking stories come from the clients in our mothers group who openly talk about some of the judgment that they experience when giving birth while engaged in medication-assisted treatment. And these experiences that they share are very challenging, you know, in their interactions with systems that leave them feeling less than. Substance use disorders are some of the most stigmatized conditions that we treat. And some people may not even want to work with, be related to, or see in public a person with a substance use disorder. But there are other members of our society that believe that people with substance use disorders should be denied housing, employment, social services, and even healthcare. It's an uphill battle at times. It can be a really hard job working with people. Things can go from feeling hopeful to hopeless very quickly, sometimes multiple times in the same day. And when we talk about words matter or person first, see, I always mess that up, person first language, the intention is not that this is one more thing that we need to add to our list of things to remember and we have to get it right, because inevitably we'll get it wrong. I think more importantly, this is about starting and continuing a conversation with our providers, with our clients, with our staff, with our friends, with our family members, you know, even the people at the grocery store, provided you're maintaining 6 feet distance and keeping your mask on. This is about a conversation about how we can change the language that we use, because in a treatment field where so much is beyond our control, what we say and how we say it is something that we have the ability to influence. I believe that the upside to changing how we speak is incredible, and it can lead to really wonderful outcomes in our clinical relationships. That was my little piece about words matter, pared down a bit from when we were presenting in our workshop. Denise, I will turn it back over to you. Thank you.
Thank you, Silas. So we did some questionnaires pre and post these workshop interventions targeted at reducing healthcare professional stigma toward those with opioid use disorder. The Opening Mind Stigma Scale for healthcare providers is a Likert type 15-item questionnaire. Higher scores denote more stigmatizing attitudes. We modified the mental illness, replaced it with opioid use disorder, again, with permission, as I previously stated. It measured four measures. One was total stigma score, and then 3 subscales: attitude toward those with opioid use disorder, willingness to seek help if one were to personally have an opioid use disorder or imagine that they did have one, and desire for social distance from those with opioid use disorder. So that's the 4th measure. There was an extra question that we asked. If you're a physician or prescriber, would you be willing to obtain the X waiver to prescribe buprenorphine? And these are evaluations, results of evaluations that were done. The comments were generally, well, they were all good, actually. Very good, great, as you can see. People said learning objectives were met or absolutely met, that the learning was effective, it increased their knowledge, should be repeated. A lot was said about the importance of language, not using labeling terms. So people found it useful. Now, on the first workshop, we got 12 of these evaluations back, and the second we got 8. In total, there were about 40 participants in both workshops combined. And the results of the survey here, the questionnaire, we got back maybe a third of those, because there were 6 to 12 weeks between pre and post. Pre was done right before the intervention, and this was also, even though it's not true research, it's a quality improvement project, it still needed IRB approval because we were working with people, so we got all of that. And the post questionnaires were done 6 to 12 weeks after to increase the validity of it, and it was also de-identified. And we linked them across time by using numbers, certain numbers, so that we knew that it was the same person before and afterwards, but we did not know who the people were. So this is from time 1 to time 2. The change, I'm going to show you a different, this is the results of the total attitude scores from time 1 to time 2. So there are possible stigma scores of 15 to 75 between the 15 questionnaires. So here, before the stigmatizing attitudes, 38.31 pre-intervention, and that decreased to 38.54, resulting with a significant p-value of 0.003. So it seems that what we did made some sort of difference in attitudes. These are the 3 subscales, and so it was statistically significant. It is, I'm going with the 0.05 p-value, less than or equal to that in 2, the first one and the third one here, the attitude and the social distance scores. And again, this is another way to look at these subscales. So you can see the attitudes toward those with opioid use disorder decreased, as well as disclosure. If one were to have opioid use disorder, also decreased pre and post, and the social distance also. The additional question regarding willingness to prescribe buprenorphine was answered by 3 providers. They were already willing to prescribe before, as they were after. In summary, healthcare professional related opioid use disorder stigma can be decreased in rural Maine using anti-stigma programming modeled after understanding stigma. Despite a small number of completed measures, the results are still encouraging. The effect size was large. And I already talked about the additional question. Limitations, small data set. There can be some confounding variables. I mean, there's so much out there right now about stigma, and there's also a push to get folks more access to buprenorphine with increasing limits. The legislation is ongoing, and short-term effects may not translate to long-term. And this is an important one. It's unknown that if we reduce attitudes around stigma, if that results in behavior change. So we don't know if healthcare professionals' behavior will be changed, and prescriber numbers are too small, like I said. But this is still important because what we did worked. There needs to be more quality improvement projects. There needs to be more research put into this, and so that we get more data. So this is how this has affected where we work, the sustainability. So administration requested that these workshops be done here. I already had talked about that a little bit earlier. And so we did 2 shortened workshops for healthcare professional at our practice, as well as one in Bangor. And that was really interesting. We took the 2-hour workshop and shortened it down to 1 hour, and very just dynamic workshops. And again, an important part of that is to involve people in whatever practice that we are going to. We would go in, and we're not the experts on this. Really important to work with folks to see where they are and what they need. And we have embedded stigma discussions about this into our monthly staff meetings. Of course, this had a little glitch here with the whole new workflow because of the coronavirus, but this will be ongoing. And we're seeking ways to embed this into our into the organization. And we're also now involved in a NIDA study, National Institute on Drug Abuse study, rural expansion of medication treatment for opioid use disorder. So that has begun about a month ago, and we were asked to be part of that. And we also have outside requests for anti-stigma workshop in various venues. We were going to do this at the Northern New England Society of Addiction Medicine Conference in November. It's gone virtual. We've not done this this actual workshop virtually yet. Maybe that's forthcoming. We need to figure that out. But for now, we're going to defer that one until next year. I believe they're going to have us back next year to do that. So it's really important. Addiction is treatable, but here's some references. Addiction is a chronic, relapsing, treatable condition. It does affect the brain. It affects everything in a person's life. It affects their social life, their work, their children, and a chronic pain specialist. As he once said, science is the basis for how we need to deal with addiction, not our beliefs. Any questions?
Thank you very much, Dr. Bouchard and Silas, for that great presentation. We've seen some questions accumulating in the chat that I'll start with hopefully a very easy one to get things rolling, which is, are your slides available for people who would like to have them after the presentation today?
Absolutely, we will make them available.
Great. We will be sending out the Q&A, and I know the recording is also made available on the Opioid Summit website for people who asked about making it available to others who weren't able to attend today. So on to maybe less easy questions. There were some questions about looking for tips about how to use this kind of work in people's own day-to-day practice or life. And it sounds like one of the questions is how to help clients not to refer to themselves as addicts. So that question comes from Deborah.
Silas, would you like to address that?
Oh, I'll take a shot. Yeah, I mean, I think that it's a common problem that we face in practice. I think the roots of it come from societal stigma and, you know, the issues that we're talking about addressing today. As I mentioned sort of briefly, I never correct anyone when they self-identify that way, but I hope that in developing a relationship with that client, we can have a conversation about addiction as a chronic brain disease and not as some sort of moral failing. And, you know, people with diabetes might not necessarily introduce themselves as a diabetic. It's just simply an aspect of who they are. It's part of their person. It isn't a label that defines them. And I think that as people can experience some stabilization and sustained recovery, the way that they view themselves and their self-confidence may change, and that label becomes less of a statement about who they are. But nuts and bolts, how to make it change, I don't have a great suggestion for that, other than to continue to have conversations with people and work with them. I haven't really seen any benefit in challenging that in somebody and saying, you're not an addict, you're a person, because that almost feels sort of stigmatizing in a way. And I'm not sure how to have that conversation in a really supportive way. So generally speaking, we talk it through, work it through, develop those other areas, and hope that provides support in changing how people view themselves. Denise?
And I just want to add that I too don't challenge it, but I do say to folks when they say that, if we're in a visit and it's just the two of us, I'll say it's totally fine if you want to call yourself an addict. That's okay. I want you to know that, but I also want you to know that that's not how I see you. Mm-hmm. I see you as you first with addiction. And so that's how I approach it.
Great. There's a somewhat related question about basically kind of challenging stigmatizing language. And Jennifer is asking about, she's referring to a training program at UNE for educating early trainees on these issues and getting waivered. And a common question that comes up is how to respond to attending. So someone who's in a position of power over you as a trainee who use stigmatizing language? What do you advise?
So we hear it is really challenging to change a culture. So we're talking about culture change here. And we have to start from where we are. And until this is taught in the schools and we learn more about it and we have more and more, I mean, it's great that you are recognizing that the person above you is using this language and you've been shown that this is not a great thing to do. So that's a win right there, I'd like to say. And it's going to be dependent on what sort of relationship you have with that person, whether or not you say anything. But here we're developing a culture at our office that when somebody says something, we remind each other. So that's what we do here. We remind each other about the language. And like Silas says, we all do it. We all make mistakes. I mean, I'd say a dirty urine, for example, where, and we'll say, okay, a positive urine instead of dirty urine. So hopefully you get there. Just practice, practice. And even if it's not said out loud, practice it in your own head.
Well, and training too, opportunities for training, you know, discussing that with the hierarchical structure and, you know, whoever is perhaps above those attendings, you know, bringing up the fact that everyone in the organization would benefit from that, because it can certainly be a really positive contribution to the relationship that providers have with their clients, and really everyone benefits from making that change. It's just, I feel like the way that we've always done it isn't a great excuse, you know, and so people who have had training previously and those were the terms that they were taught, okay, well, we need to throw those out and we need to select some new terms, because we're seeing the impact that stigma can have on people's access to treatment. And, you know, it's, the stakes are high. So it's worth taking on that challenge.
I realize I forgot to mention at the beginning in the introduction that our office used to be called Substance Abuse and Mental Health Services until January of this year. And we still have to catch ourselves and call each other out sometimes for accidentally still saying substance abuse as opposed to substance use disorder. So it's habits that have, take conscious attention to change. There's another question in the chat, or in the Q&A, about what do you think of state legislation requiring all people who prescribe opiates to obtain an X waiver, not necessarily to prescribe buprenorphine, but to have the education and ability to prescribe? And that question's from David.
The education and the ability to prescribe buprenorphine?
Yeah, so it sounds like the question is do you have a perspective on possible or the idea of legislation requiring people who prescribe opiates to also obtain an X waiver, not necessarily to require them to prescribe buprenorphine, but to have the X waiver education and the ability to prescribe is the question.
So I think that I don't know about that legislation, and so I don't really have an opinion on that. Chronic pain specialists do not take off if you don't know how to land. Don't start prescribing opioids if you don't know how to get people off of them. And I'm talking about opioids for chronic pain. So absolutely, education around that. It doesn't mean you need a piece of paper to, I mean, our education that we get through school should suffice, but a lot of us haven't had, we're catching up with the education now. I hope that makes sense.
Yeah, I don't have much to offer there other than, I mean, certainly more training is always a good thing. And for people to pursue that knowledge on their own makes a lot of sense. I'm not sure about requiring it, but it feels like a bit above my pay grade, so.
It reminds me that might be worth mentioning in this context about our partnership between the Office of Behavioral Health and PCHC and St. Joseph's Healthcare in the context of the Schmidt Institute and that work around helping prescribers who need support around deprescribing opiates and other kinds of education. So I'll put a link as well about that program into the chat. And let me just see if I, Denise, did you want to weigh in on that?
Make another comment, unless you have another question.
Nope, you go for it.
Okay. I just want to, there is a wonderful PowerPoint called Neuro, the Addiction of Neuroscience, the Neuroscience of Addiction 101 by Dr. Corey Waller. It's a great, it's like 23 minutes long. It describes about what happens to the brain and why these medications are important. And he talks about discrimination. He talks about, he makes this point. When you go, if you have a heart attack and you go into the emergency room and just the red carpet is rolled out for you. And why is that? That's because we have a system that is built to take care of folks with physical issues. And I mean, the stuff that's in place for that is incredible. You walk in with an overdose and you're back out on the street the next day because we don't have the system to capture that person and get them directly into treatment. This is regardless of whether or not they're willing. The system's still not there, even if they're willing at times. So that's not stigma, that is discrimination. And that goes to systemic stigma that's been going on, that's just embedded in our society. It reflects the unequal social determinants of health. And so I'd like to invite folks to think about that. Why is that? And he also said that it's unacceptable to remove somebody with addiction out of primary care or anywhere else in the healthcare system when their behavior is bad because of addiction, because that's how we define it. That's the diagnosis. And we should assume that a behavior is a symptom and not a frustration.
It looks like we've got 1 minute left, and I did just put some information about the Controlled Substance Stewardship Program through the Schmidt Institute, which feels like a tongue twister, into the chat. And I don't know that you'll have time to answer the last question, which we can put into writing. It says, what should be the correct destigmatizing name of one 85-year-old organization utilizing 12 steps toward recovery? And the suggestion that's put in here is organized group of persons suffering from an ethanol misuse disorder who wish to be minimally identifiable lest they feel a hint or more of stigma from others who do not suffer this malady. It's catchy.
What's the acronym for that?
Alcoholics Anonymous. Oh yeah, what's a, that's it doesn't come out so handy. OGPS. It's a long one, but I appreciate the suggestion and everybody for attending and participating, and we'll look forward to doing this again in November. Thank you so much.
Thank you, everyone.